Okay, I did it. It says it's streaming on Facebook.
We see it.
Okay, I think we might be live. But I'm not 100% sure. Oh, we are. We are live on the Facebook. Cool.
Yay.
Okay, so welcome everybody. Oh boy, I can't actually hear both. Okay. So we have a couple of guests already. My sister-in-law, Megan Neff, is here. Hi, Megan. Nice to see you. And I want to start off with some introductions. So we'll just kind of wait for people to join us and say some stuff while we're waiting. So my name is Malia Jones, and I'm a researcher at the University of Wisconsin-Madison. I normally study herd immunity and spatial patterns in herd immunity that play a role in how epidemics spread in mostly in vaccine preventable diseases. But since COVID-19 broke across the world, I have been studying and doing a lot of public engagement around COVID-19 specifically. So part of that is to have started, along with 10 collaborators, this page, Dear Pandemic, to try and get real factual information out to the general public. And so I want to welcome everybody to our first live on Facebook event. Bear with us because this is the first time we've done this, and it's a little, it's new technology for us. So I'm going to be moderating today. I will take questions. You can put them in the comment box on Facebook, and then we'll pass it over to our other nerdy girls to answer those questions. So let me turn it over to Jenn Dowd, who's the next person in the gallery view that I'm looking at. Jen, we can't hear you because you're on mute.
Sorry.
There you go.
Rookie mistake. Sorry. Hi, I'm Jenn Dowd, and I'm a social epidemiologist and demographer at Oxford University in the UK, but you can probably tell I'm American. So I'm kind of closely following developments and differences in each country's approach to COVID mitigation. It's been very interesting. And my research has typically looked at how social factors affect health. And I've done a lot on, along with Amanda, on looking at chronic infections and immune function and how things like chronic stress over the life course affect immunity and different types of infections. So that's kind of how I fit into a little bit of COVID, but it's been a learning curve for all of us. So happy to be here. Thanks.
Great, thanks, Jen. Amanda, do you want to introduce yourself next?
Hi, everybody. I'm Amanda Simanek. I am an associate professor of epidemiology at University of Wisconsin-Milwaukee. Similar to Jen, I study social determinants of infectious disease and have focused primarily on herpes viruses in relation to chronic disease outcomes, but I have also dabbled in respiratory infections, spent time working on a study at University of Michigan, where we looked at the role of voluntary isolation on spread of respiratory infection over a course of a flu season. And so I do have some background and understanding of transmission dynamics of respiratory infections and generally the type of public health interventions that we might use that are not pharmaceutical to prevent the spread of a pandemic. So thanks for having us today.
Thanks, Amanda. Okay, Lindsey, would you introduce yourself?
Sure. Hi, I'm Lindsey Leininger. I teach healthcare analytics and evidence-based healthcare at the Tuck School of Business at Dartmouth. I am a health policy researcher by training and trade, and typically I advise state and some federal policymakers on data. My work focuses on vulnerable populations and the healthcare experiences of these populations, which is how I got involved in becoming a COVID person right now, because obviously there's a social patterning to what's going on among populations with different vulnerabilities. And it's been so fun to be part of a Nerdy Girl club.
Great. Thanks, Lindsey. Your mom is watching, by the way. She says hello.
Hi, Mom.
So is my dad. So hi, Dad.
Emily's dad. And I will say, my mother and her sisters are sort of like original nerdy girls in my family. She is a math teacher, and 2 of her sisters have PhDs in biology. So
Great.
yeah, carrying on the family tradition.
Absolutely. Okay, so let's jump over to the questions. We have a couple of questions that we have to get started with, and then anybody who has questions who's watching should post them in the chat box, and I will try and keep up to date with these. So just before we went live, we were talking about this question: when can I send my child back to daycare? It's next to impossible to work while my little ones are at home. And maybe this is a good one to start with also, because all 4 of us have young children, I think, at home, and they might interrupt us. So bear with us as we do that. So let's see, I think, Lindsey, you had some thoughts about when we can send our kids back to daycare. You want to get us started there?
Yeah, so this is of desperate interest to me, having an 8-year-old and a 4-year-old. Again, as Malia pointed out, they are my teaching and research assistants. I'm sure we'll hear from them at some point on this. So as a collective, we were kicking this around, and according to the federal guidelines, it may be a phase 1 type reopening, which means sooner rather than later. But I think that we will probably see a differentiated set of recommendations. Most of the guidance around these things is actually coming from the states as life continues to evolve. So pay attention to your state and make sure that, we have to make sure that the children of healthcare workers have kind of privileged access to existing spots. And 2, that we as a collective and you as a state and your daycare center has good practices around how best to reopen to non-healthcare workers' kids safely. And if others want to jump in, I'd love that.
I'll just add that some of the recommendations right now around how to maintain social distancing in those settings will have to be scaled up to accommodate children that are outside of healthcare workers' children. So I think that's something that we can be looking for guidance around and information around how and when centers feel like they can adhere to those guidelines on a larger scale.
Great, thanks, Lindsey and Amanda. So let's tackle another one that we got in advance of the live chat here. If there's been a lot of asymptomatic spread, which is one of the things that we're hearing in the news quite a bit, aren't we already close to herd immunity, and can we go back to normal at this point? Amanda, you want to tackle that one? And then I think maybe Jen will have some insights there too.
Yeah, so we do suspect that there's a fair amount of asymptomatic transmission with this virus. There's been a few small studies that have tried to quantify the extent to which that's happening, but on a large scale, I don't think we have a good sense of exactly what proportion of the population has been already exposed. And to find that out, we need to institute large population-based studies where we test for antibodies to determine sort of who has the presence of antibodies. That would give us some indication what proportion of people might have been already exposed. And then beyond that, I think we need to learn more about how long immunity lasts, or what sort of antibody levels mean in terms of the extent to which you might have immunity. So there's a fair number of questions, even once we get a sense of who's been exposed to the pathogen, how long, and to what extent immunity might last over time. And so I think there's a few unknowns out there right now around that. And I'll turn it over to Jenn to add.
Yeah, I'll just add, because I've been seeing a lot of questions about this too. And I think we would all love to find out that there's been a lot more asymptomatic infections than we're aware of, because it would mean that possibly the fatality rates are not as high as we think, which would be great news. But as Amanda said, there's been a few studies, and even in real hot spots, there was one study in Germany in one particular town that was hit hard, and they found, I think, around 13 or 14% evidence that percentage had been previously exposed in a very heavily hit area. And I think the other thing to remember is that in order to approach herd immunity, and Malia might know better, but we think at least something like 60 or 70% of the population would need to be exposed. So I think all the studies that are coming out now are going to be helpful in helping us understand, but I don't think we're going to suddenly find out that we're super close to herd immunity. So I don't think it's going to dramatically change the actions that we have to take to protect, 60 to 70% of the population from getting it going forward. So it is something I think the sero studies that Amanda mentioned are going to help answer. And I believe Governor Cuomo just said that New York State is planning to do that in a systematic way. So given how heavy of infections they've had, that will be a really useful study to give us a sense of the overall prevalence. But overall, I think we have to not count on that as an exit strategy, unfortunately.
Yeah, I'll agree. And I'll just add, one of the things that I've heard this number being tossed around, that we need to get to 20 or 30% for herd immunity. I have been trying to track down where that misinformation came from. That is not a good estimate of what we would need for herd immunity for this disease. The actual number is not known yet, how many people we would need to have population level protection against further spread. But it's, just based on what we know already about the disease dynamics, it's going to be at least 60%. And my guess is much higher, probably near 80. So we're nowhere near herd immunity at this point. If we had 80% of people exposed already, I think we would have seen the corresponding people showing up in the hospital with severe symptoms much earlier. So I just don't think it's possible for the disease to have spread through 80% of the population so far. So yeah, I agree there. Let's take one that we just got posted live. Someone asked, Megan Reed asks, is a vaccine in 18 months realistic? I heard no. There's no vaccine for cold, for example. And if not, then how do we get out of this? Anybody want to take that one?
I can take it.
Great.
So at a lot of my students here at the business school go into the life sciences. So in my classes, we talk a lot about the data requirements for the FDA, and it's pretty amazing, actually, that there is already a shot in a human arm for the vaccine. So that should give us hope, right? That it is literally in humans right now. You read people who are experts in FDA regulation, and they think that 18 months is doable. It's optimistic, but it is doable. So again, I don't have a crystal ball, right? This is my favorite thing that Dr. Fauci says. I don't have a crystal ball. I can't predict the future. But unlike the herd immunity scenario where, I don't think we're there, like on the vaccine front, I hold out hope, given that there is a vaccine in a human arm and that the FDA is working pretty hard to speed this through regulatory review. And fortunately, we don't have all of our proverbial eggs in one basket, right? There's over a dozen vaccine candidates right now, and that kind of grows by the day. So I am hopeful on the vaccine front. Others?
Yeah, I'll just say I agree. It's not, vaccine development is not my particular area, but I know at Oxford there's a team that works on vaccines regularly and had worked on MERS and the other SARS vaccines, and felt like they had a really good candidate kind of that they could ramp up quickly. And this seemed really optimistic to me, but they claimed there might be something by September and that they're already ramping up doses that if efficacy was proven, that they'd already have ramped up production. So that may be super optimistic, but the fact that they're confident enough to even say that, I think, is a good sign that with all of the great talent, putting their heads together for this, I feel like we will get there, but possibly, yeah, it'll be a little bit of a wait.
Yeah, and to amplify what you said, John, the rate limiter here isn't necessarily the science, right? It's you just have to wait to see vaccine safety profile. You just cannot speed up a study about safety, unfortunately. And again, I wish that weren't the case. So I think what we're going to see with the lag is we just have to have a sufficient amount of time and numbers of populations tested to get a robust enough safety profile to actually scale.
Great, thanks to you both. Let me turn to another question that we got in advance. Can I visit my elderly parents? We have all been isolated for weeks. Amanda, do you want to tackle that one?
Yes, so before the pandemics really ramped up, I was in London away from my family and friends for 3 months, basically isolated, except I got to see Jen. That was good. So I hear you, and I hear everybody who's longing to visit family, because I barely saw any of my family once we got back, and then we have been under safer at home. And I think even though families are, if you're doing a good job isolating within your household, one of you is still likely going to the grocery store or spending some time outside your home. And I think, your parents are probably also doing that, right? And so anytime we sort of open up a path for there to be transmission between us and other people, and anytime we're outside of our homes, we're still having the potential to be exposed to coronavirus. And so I would refrain from doing interactions or getting together with family, even if you've been isolating for a few weeks, just because there's still that opportunity to transmit. And because people who are older or have chronic health conditions are at greater risk, that could be your family could meet those criteria and you'd be at increased risk of complications and death if they acquire the infection. So I think, the more we can keep our social contacts limited at this point in the trajectory of the pandemic, we need to do that still.
And we got a couple of related questions about, can we have play dates if the other family has been isolating from everyone else? And then there's another one about planning a vacation with another family that has also been isolating. So do you think those situations are any different?
No. I'll jump back in and say, no, you basically subsume the risk of their exposures when you sort of combine households, whether it's for a play date or for a vacation. And so that means that the risks that their risk of exposure becomes your risk of exposure, right? Like they went to the grocery store and had exposure, you get together with them, it's the same thing as if you had gone to the grocery store and had exposure. And so the more we open up our social circles, the more personal risk we have, and then the more risk we have that next time we go to the store, we will transmit to somebody else.
Yeah, one useful way that I like to think about it, we also have older parents, grandparents of my children who live nearby, and we would really like to visit them. But I every time I think, well, maybe it's okay at this point. We've all been home for a month. It's probably no big deal. And then I think, oh, but I was at the grocery store last weekend. What if I got sick the day after we went to visit them? How would I feel about having exposed them at that point? Okay, so how about this question? What do you think is the reason for the hotspots that we have seen? Why is one place breaking out and another place seems to be lower than expected? Wisconsin, for example, most parts of Wisconsin are lower than were predicted about 3 weeks ago, whereas New York City is still appears to be, the epidemic still appears to be growing in New York City, even under extreme lockdown conditions. So anybody want to field that one?
I'm not sure I have a great answer. I'd love to hear some of your thoughts on variation in the US. But one thing that my research group looked at initially when things were getting so bad in Italy was trying to understand, what might be the reason for that. And Italy is actually one of the oldest countries in the world. It has over 23% of its population over age 65. And we've seen that a lot of fatalities are concentrated at these older ages. So we thought that was one reason that we saw a lot of deaths there. But actually in combination with the fact that there's a lot of multi-generational families in contact in Italy, between younger people working in Milan and then living out in the villages or commuting back and forth. And so one thing I think that's been interesting about New York City is that it's not the most dense areas like Manhattan that have been hardest hit. It's been more immigrant communities. And I think there very well could be something with these high levels of intergenerational contact that help spread the infection from more asymptomatic or mild cases to these more vulnerable populations. And so I think that's one thing that seems to make sense there. But I think it might make sense to kind of look at how these demographic things vary across the country and even local areas to see what might be vulnerable areas for hotspots.
And Amanda, do you think you can, do you have any comment on why some places are doing better than we predicted them to do, say 2 or 3 weeks ago?
Social distancing. Yeah, I mean, I think that's a highly that's a possibility, and I think it's a testament to the success of social distancing, right? So some of the recommendations around social distancing are that you don't travel to other parts of your state, you don't go to your vacation home. So I'm in, Malia and I are in Wisconsin, and that was one of the recommendations by the governor. And so in those more remote areas, if we've had less people visiting, then there's less opportunity for transmission to areas that are more rural, that the population's not as dense. And for many of those areas, those are, towns where the average age is older. And so we do want to protect those populations who also have fewer hospitals and other, resources from that infection. So I do think in part that is a success of social distancing.
And I also, in addition to social distancing, I want to give a plug for good old fashioned public health. So I'm going to tell a story. Here in New Hampshire, Grafton County, that's where Dartmouth and its environs are located, we had one of the first confirmed cases in the country. And it was somebody who had returned from Italy, had contracted the virus, had unfortunately been told to quarantine and didn't, and instead went to a social event for the Tuck School of Business, which is my employer. And this was cause for a lot of alarm and panic. But I have to say, our public health department blocked and tackled. So this whole test, treat, isolate, right? Test, trace, isolate, it works. And I know that there's a similar situation, in other places too, right? So like ours has been reported in the newspaper, so I'm not sort of like speaking out of school or anything. This is very well known. So I think this is why people like us, we sound like broken records, we sound like scolds because we won't stop talking about testing. And I'll tell you why I won't stop talking about testing. It's because Dartmouth has not had an explosion of COVID, even though we had one of the earliest cases because there was a test.
Great, thanks to you both. So let's turn to something, let's actually talk a little bit more about testing. So say some more, Lindsey, about why is testing so critical to reopening the economy? Why is that the thing that the scientists just keep saying?
Yeah, thanks, Malia. And I think, I'm eager to hear y'all's take too, but it's medical intelligence, right? Businesses do not plan for expansion or continued operations without some sort of market intelligence. And until we have testing, we have no medical intelligence. Point blank. So not only is it important at the individual level, like let's keep this person who has it and do the right thing by them in their context. It's also at an aggregate level. How much in the county? How much in the state? How much across the country? Both of these are necessary for market assessment, right? Similarly, both of these are necessary for public health assessment.
Amanda, I know you have thoughts on testing too.
Thanks, Malia. So testing is really the trigger for doing contact tracing, getting a positive case. And so if we don't upgrade and ramp up our testing capacity, those other public health actions don't get triggered to take place. And so if those don't take place, we don't execute those strategies for identifying who's a case, who was their contact, directing those people to engage in self-quarantine and to minimize their contact with others while they monitor for symptoms. That is going to be one of the ways that we are able to relax social distancing at some point, is to really ramp up those efforts, hire more people to do contact tracing, have more labs on board to be able to do tests, relax the criteria that is currently in place for who gets a test, increase access to disadvantaged communities so they can have tests freely. And so this is all going to be pivotal, I think, to us transitioning away from these kind of stay-at-home orders to re-emerging into the world is going to be our ability to utilize those tools of public health. And so testing is paramount to that effort.
Yeah, I agree with that. I've been telling everybody the reason everyone is stuck at home right now is because we don't know who has it and who doesn't. As soon as we can figure out who has it and who doesn't have it, then only they need to be stuck at home and the people that they've been in contact with. So testing is the only way forward. And then we also need contact tracing for those exposures for positive cases. So I want to turn to this somewhat more complex question that we got in advance of the live. And I think maybe Jen might be best positioned to answer this one. So we were linked to an article from the Daily Mail about mutations in COVID-19, genetic mutations in the virus, saying that there are 3 different strains out there. And the question is, if this article is accurate, that there are 3 different genetic strains out there already, or maybe more. There was another article that suggested there are actually 8 or maybe even more strains. Is it possible or likely that the virus will mutate more times before there's a vaccine? And how does that affect what we know about the virus and about vaccine development? Jen, is that in your wheelhouse?
No, I'm happy to give it
okay.
Give it a go, but I should say that I guess none of us are virologists officially, so we're kind of
I was thinking
unofficially.
or unofficially, right? I was thinking more from a population health perspective, and I can actually come back and talk a little bit about what I know about vaccine development, although I am also not a virologist. So
yeah, no, so we're kind of doing our best to read the scientific papers underlying these news articles and interpret them based on our broader expertise. And so, but this is a great question because we have seen the similar things, and I think the good news is that in general, these coronaviruses seem to mutate much slower than flu viruses, which probably a virologist could explain, but something about there's not as many surface areas to change over time. So while there will be some drift, I think conceptually we're much more hopeful that a vaccine that would at least be stable for 1 or 2 years is more realistic. So I think the genetic drift that's happening now is helping us to track kind of geographically the spread, because these are very slight changes, but I don't think they've changed the character of the virus into completely new strains yet. So I think we do think that it's going to be a little bit better of a picture than flu as far as length of immunity, possibly 1 to 2 years based on other coronaviruses. And that should be enough for us to have a good vaccine target that won't change too quickly. But I'd love to hear Malia's thoughts on that.
So that's similar to my understanding from what I've heard from people who are virologists. There are degrees and types of genetic drift, and the kind of genetic drift that we're seeing with SARS-CoV-2 is not the same as what we see with flu, where it makes it hard to develop a universal vaccine. And so we still are hopeful that the universal vaccine is going to be possible, even though we are seeing some of this genetic drift. But as Jen said, I think it's really interesting that we can use that kind of genetic drift to date the spread of the epidemic over time and space. And so one of the things that we've learned from studying those genetic changes in the virus itself is that most of the cases that were introduced into the United States, especially on the East Coast, actually came from Europe and not from the origin point in Asia. So they were people who were, so the virus didn't jump directly from China or other points in Asia to the United States, but it probably came in mostly from Europe. So interesting notes there. So let's take a little bit more lighthearted one. What is the most common question that you're getting right now? Maybe that's not lighthearted at all. We'll do an actual lighthearted one next. How about Lindsey? Do you want to take?
Oh, I lost audio. Can y'all hear me? Okay. What's the most common question? I feel like the grocery thing, right? Like I think there's just never enough good information coming out about grocery shopping, takeout, food safety in general. So I usually send people to the CDC, but let's be honest, that's horribly turgid, unhelpful prose in a lot of cases. I like Consumer Reports. They've been pushing out a lot of really accessible science-based info about food safety, including grocery shopping. So I think that continues to be number one on my hit list from folks.
So actually somebody asked us to go over the recommendations for grocery shopping. You want to just tackle that now?
Yeah, case in point. I don't need to field the question, but I think that is just a great anecdote.
So there are a couple of good resources out there, videos that go over how to practice safe grocery shopping. But I don't know, Jen or Amanda, do you have sort of the top 5 for what we should do while we're grocery shopping?
I can go for it, but if you have other ideas, different top 5. I think that what I have been telling people, if you have one partner in your house who has to leave the house to go to work, then have that be the same person who goes to the grocery store. Like there's no point in exposing more people in your household to the virus than is necessary. And believe me, this bothers me because I love to do the grocery shopping. My husband never gets the right deals or things that I want him to buy, but I have to be the one who's grocery shopping. And then some, places are limiting the number of people in the grocery store, which is helpful for maintaining a 6-foot social distance from others, right? So to the extent that you are able to adhere to those social distancing guidelines in the store is ideal. CDC a couple weeks ago recommended that when you go out into public spaces where social distancing can be difficult, that you wear a cloth mask, a homemade mask, not a surgical mask, not an N95 mask. And so the point of wearing those masks in those types of settings is so that actually if you are asymptomatic or breathe, cough, sneeze, or anything, that the germs, the virus particles, droplets that you might expel get trapped behind your mask and protect other people. And so that's advisable. And I'm not sure what the latest recommendation is on using homemade or cloth grocery bags or reusable grocery bags. Maybe someone else can weigh in on that. And then when you bring your groceries home, what I've told people is just, keep everything in one spot. Like, don't spread it all over your kitchen and make it harder to clean up after, yourself if you're worried about any kind of contamination. I'm personally not wiping down all of my groceries, but if I, kind of keep everything in one spot, put it away, wash your hands, after you put everything away and wipe down the counter. I'm not taking other precautions beyond that, but maybe you guys can weigh in.
I'm not, also, I can speak to that. So I am also not wiping down my groceries, but if anyone, if your personal risk profile is such that makes you happier, I think that is a great thing to do. And Sanjay Gupta has a really good bit on that. You can Google that on CNN, where he actually is in his kitchen telling you how to wipe down your groceries. It's pretty entertaining TV in addition to being useful.
You get to see Sanjay's kitchen.
But totally. He has a great kitchen. It's really pretty.
I'm not surprised. Jen, are you wiping down your groceries?
No, I'm just unpack. We're getting them delivered. I guess in London, we've been doing that for a long time because we don't have a car.
I'm not sure I understand.
Oh, my Siri doesn't understand. And no, I'm just unpacking and then washing hands, but I'm not wiping down.
So we actually are wiping down some of our groceries. We have a garage, and what we've been doing is bringing everything into the garage and parking it there for a couple of days. And the stuff that can't be parked in the garage and has to be put away right away, I am wiping it down for the most part. It's exhausting, though. I will say it really gets old, and it's tearing up my hands to be in contact with that much chemicals. So I promised a lighthearted one next. What is the funniest question you have received during the pandemic? Nobody volunteered in advance to answer this one.
Okay, I have to give a shout out to our fellow nerdy girl, Lauren Hale here. I did not get this question, but she posted about, toilet plumes? Like, basically it is like flushing the toilet. Like, is it just gonna, be the end of all of us? I laughed so hard when she posted that. I don't know about y'all, but I just thought that was so funny. It was science-based, but yeah, I thought that was pretty funny. I think the takeaway from that is, like, close the lid on the toilet before you flush it.
I think that applies always, though.
Yes. Yeah, I think the toilet plumes it's not limited to COVID-19.
Not limited to COVID.
Like so many public health interventions, like washing your hands and, washing with respect to groceries, one of the things that I always wash my anything with a peel on it, especially if it's something you're going to eat raw, because my family got food poisoning one time from a melon. And so I always scrub my especially watermelons and cantaloupes down with dish soap before I slice into them. And so, yeah, some of these things are just good general public health practice, right? We should wash our hands and not cough in each other's faces. Amanda, have you gotten any funny ones? No, it's not a particularly funny situation, really. The toilet plume was amusing. We have a bunch of questions about when are things going to be normal, and in particular specific situations. So will summer camp be open? I'm planning to go to college in the fall. What's going to happen in the fall? I fielded one this morning from a neighbor who wanted to know if we could plan a large community event for late in the summer, an outdoor community event. Somebody else asked, when are we going to be able to have social events like weddings or bar mitzvahs with 100 or so guests? So any thoughts on when? I'm going to preview the answer. It's complicated.
Yeah, and I think everyone, as folks know, it's phased, right? So I just read this morning a really nice report put out by the Johns Hopkins Center on Global Health Security. They're the folks who have been doing a dashboard that's been well received, and they stage it, right? So like the large event of more than 50 people, I think we just can't plan on that happening for a while, right? I think a small event of 10 people outside where everyone's 6 feet away, that's going to happen first. And again, there's some directions in the federal phasing, but I think we just have to use our common sense too, right? Like in a large gathering, there's a lot more exposure. So college, I think that's TBD for the fall, honestly. I think most people are suggesting it's probably, well, I don't want to get too far out over my skis, but if you think conceptually about what college is like in terms of exposure, you can see it being a later phase. I might let Jen speak to this, but yeah, so I think a phased approach.
Yeah, I was just going to say, Jen, you want to talk a little bit about social networks and how we can think about risk?
Yeah, I guess first I'll also just talk about in general about the timing. I think it's true that, people really want an answer on that. And I think it's going to change every couple of weeks because we're learning so much and from different parts of the world as well. I think the fact that parts of Asia are, they're not going back to the way life was before, but they're going back to some semblance of regular life, but with a lot of kind of the more basic social distancing and public health measures baked in. So I think we're going to learn a lot in the next few weeks from that. But I think it's absolutely right that it's going to be gradual, and then we're going to have to reevaluate, every couple weeks as we introduce kind of more contact. But yeah, so my research group so I'm not a social network scientist either, but we've done, one of my colleagues has done some work looking at how we might be able to use insights from social network analysis going forward. The fact that we might not have to limit all social contact, but kind of the things we started recommending early on, that if you can limit your social networks to groups that have repeated contact with each other in a more isolated way, when you take that across the whole population, it really does reduce the overall risk of transmission, of more distant transmission chains. So I think we're going to have to think of more concrete strategies that can be sustainable over the long run for reducing social contact. And I do think that makes school and college, particularly tricky, because that automatically, increases dramatically the number of social contacts. But I have a senior in high school and thinking about college. So it is heartbreaking to think of these kids not being able to go back to that environment. And so I do think there's still a lot of time between now and July or August when the universities will make those decisions. But if you want to be cautious, you might want to start thinking of some alternatives, I think, for the fall, if you don't want to do online college, which is, less than ideal.
I have some other thoughts to add, just on the immediate things that we're probably looking for to indicate that we could enter phase one. Like, we should be looking for sustained reduction in cases in a given area over a 14-day period. Many of the places where the outbreak is happening in cities, we're sort of still either climbing the peak, or we definitely haven't descended all the way, the peak that we've been trying, or the curve we've been trying to flatten. And so that's one indicator that people are recommending, that, we should be looking for consistent reduction in cases and decrease in that slope of the curve. And then those other points that we mentioned before about capacity for testing to be ramped up in your locality, the influx of resources around contact tracing, like those are some of the things that will be necessary to even consider entering phase one reopening, right? And then it will have to happen in a sort of staggered, slow, deliberate way, so that public health workers and epidemiologists can say, okay, we did this, now are we seeing a surge in cases or not? Is it a surge that we can handle both from a contact tracing and testing capacity, as well as a health services capacity, right? So these are going to be some of the trial and error that has to happen as local governments almost experiment with different ways to reopen society. And it's going to take patience and a little bit of learning as we go along to understand what the best course of action is.
Yeah, I just want to signal boost what Amanda just said. I think I've been telling a lot of people that the things we need to see, you know, a lot of people, probably the most common question I'm getting right now is when are we gonna, like, is it, okay, the governor just extended the safer at home order. Is it gonna be extended again? When are we gonna get out of this? And I don't know when. I don't have a crystal ball either, but I think what we're looking for is for there to be, as Amanda said, a sustained decrease in the number of cases over about a 2 or 3 week period. We also need to see that the healthcare system is below capacity and can handle another wave of an outbreak. And we need to see testing available to anyone who has reasonable suspicion of exposure, including people who have no symptoms or are just a little sick at home. We don't have that yet in most places, and we need to see the ability for the state or local public health agencies to be doing contact tracing, which is an incredibly labor-intensive process, and it can't be done on a lot of cases. It cannot be done large scale because it's so labor-intensive. So we need there to be very few cases in order to do that. So there are a number of components that I think, as Amanda said, need to be in place before we can start phasing out the safer at home. So I have a couple questions here about sort of related. One of them is, for those of us who are older and have existing health issues and might be in the highest risk group for death or really poor outcomes when they get COVID-19, are we going to be stuck at home until 2022 when a vaccine is available? And then related to that, there was also that article in Science about the, and then I think it was quoted in the Atlantic article called Our Pandemic Summer, about how long this is really going to take to go back to normal. Anybody want to tackle that one?
I don't have a silver bullet answer, but I will say we have clues that you don't have to hold yourself up in the fetal position in a corner till 2022. People in our society have been dealing with medical fragility. If you think about cancer patients, if you think about medically complex children, right? We have resources and other populations. The disability movement has been putting out some amazing information on this front. So I think while extra caution is going to be necessary, you are not alone. And we have some really good population-based advice from communities who've been dealing with this for a long time. And they all start with wash your hands, stay 6 feet away from people. And again, you know, using Malia's phrase, I like signal boosting. This is old school public health stuff, right? So I don't think I don't think despair is necessary.
I would add to that we will get clarity over time about how many people have been exposed already in the population, and ways to be strategic to reintroduce, you know, parts of our social interactions while protecting vulnerable populations. So I do think with the tools of public health and you know, other fields, we will get there, you know. And no, I don't think that it's going to end up where certain vulnerable individuals and have to hole up in their home for the next 2 years.
Sorry, I was on mute. Jen, do you have any thoughts to add on that one?
No, I agree with Amanda. I would just say it's been, I think for all of us, it's been an up and down cycle of kind of optimism, pessimism, optimism. And it has, for me, gotten a little more real, you know, that this is going to take a long time to sort out. But I also see all of the work going on, not only in public health and medicine and all the things clinicians are learning on a daily basis, treating patients. And so I do have a lot of faith that we're learning so rapidly on all fronts that it's not going to stay, you know, the way it is now. This was really meant to buy time for all the learning that we are doing. And I agree, we can be more strategic and more effective as things start to open up. And So I'm optimistic that, yeah, again, that humanity kind of focusing all its efforts on this one problem is going to be, we're going to discover some amazing things in the end. So fingers crossed.
Yeah, I have never seen the scientific community broadly respond to anything so quickly. It's really incredible how fast new information is coming out. I mean, it's literally daily that we get new science and new options. So I think it takes some patience, and I've certainly had my days of despair as well, but we do learn new things over time. And so, yeah, I don't think we'll just be in this holding pattern until 2022 either. So we have only a couple minutes left here. I want to turn to a couple of more broad questions. What do you think is the most difficult misperception that you are dealing with right now?
Yeah, I'll lead. I think it's the cruelty of exponential math, right? So this comes up from friends of mine who are in places, fortunately, that haven't had big outbreaks, haven't had a lot of deaths, and they don't understand why they have to be shut down. And we think of the pain of small business owners and people who have lost their jobs, and they're asking very understandable questions around, why has my livelihood been shut down when my community's fine? And I think part of it is that exponential math sucks. It is cruel, right? So while their communities are doing okay now, one case turning into community spread can lead to the next New York City. And it's a hard thing, right, to weigh a risk that's exponential in the near term as opposed to something like a lost paycheck that hurts you right now.
And there was actually a related question to that. Somebody asked, what's the rationale for not traveling to your vacation home within the state? And I think that's the rationale, is that, you could be carrying that one case to a rural, especially in Wisconsin, to a rural place that has essentially no capacity to handle a COVID-19 hotspot, and also has a very high number of older people who are at higher risk from complications. So that answers another question too. So let's see, Jen, do you want to say what's your most difficult misperception?
I would say, yeah, along those lines, that there's a really kind of no-sum game between public health and economics here, which I think most economists that you talk to have a lot of the same concerns about opening up before test and tracing and things are available, because if it is let loose and we get hotspots similar to New York City all over the place, that's way worse. Well, that's terrible for the economy as well. So I think there's not a strict dichotomy between the economy and public health, and everyone wants the same things to kind of open up safely and strategically. And so I think we shouldn't start pitting ourselves disciplines against each other. We can accomplish both goals. And we're all aware as social epidemiologists of the importance of, the economy and jobs and security for broader health. So we're all concerned about that. But then maybe—
And Jen, can I amplify that point just real quick? So I am a public health professor in a business school, and I have not one trace of cognitive dissonance. She's right. Jen is right. I mean, I think smart business people and economists know we have to stamp this out now.
Yeah, absolutely. And I'll just throw another one out there that maybe other people want to chime in, but because I've studied this also, sort of the age pattern of mortality is really concentrated at older ages, especially in Italy and Spain. But I think in the US, we're seeing, a slightly younger age profile of mortality and serious hospitalizations and complications. And so I just want people to realize that it's, we can't say it's just this other vulnerable population that's not gonna, come into my household. That, first of all, we all know plenty of people and loved ones over age 65, but, it is striking younger people, luckily not as many kids, which I think is one really lucky feature of this particular infection. But the US, obesity is a risk factor, hypertension, there's lots of underlying conditions that can make people vulnerable to complications. So we shouldn't feel just like it's only affecting this small group of vulnerable people. We all need to be careful.
Amanda, how about you? What's your most difficult misperception?
I think the sort of misconception that once we flattened the curve, we were done, right? That was the first step, right? And a totally necessary, urgent tactic for us all to take because of the need to ramp up these other tools that we can use to sort of maintain containment of the outbreak over time. And so, you know, we're seeing pushback now that curves are in the flatter stage in many areas. But as I said, we need to actually have that curve descend over time to feel like we're in a place to utilize other tools that we have. You know, so I think there's been a lot of disappointment, like, oh, stay-at-home orders just got extended, you know, and I think just trying to clarify that, you know, this is sort of the purpose of what we're doing right now, is to step back and say, okay, we need to protect people, protect our healthcare capacity and plan. And so it may, you know, take longer. I was saying to someone, you know, it's really been 3 weeks in Wisconsin. And I think about all the decisions that have had to be made by public health professionals during that time, between going from 2 state labs that were doing testing to now 23 labs that are on board doing testing, securing and taking inventory of PPE across the state, identifying alternative care facilities in case we need them. I mean, so much has happened in 3 weeks that I think the people, you know, people who are just know that they have to stay home, or they're losing income, or their children are home. It's hard to know what all that is happening behind the scenes, and why this pause is necessary, and why it has to continue in some locations so that we can keep that planning process moving forward.
I agree. It's been probably the longest 3 weeks of my life, and I can only imagine how long it has been for people who are working in the state labs and the Department of Public Health and other decision-making roles. It's been a rapidly changing environment. This is one of the things when people ask me, are summer camps going to open? I'm like, I could never have predicted where we are today 2 weeks ago. So I have no idea what to tell you about summer camp. Yeah, I think I'll just answer. I'll answer that briefly. For me, the hardest misperception is surrounding what are the models telling us, and what even are models, and why have they been wrong in some places. And you know, I think most people don't deal with models, predictive models in general, except for the weather forecast. And in this case, you know, we're all trying to make models using very, very scarce data. And so if it feels like they're wrong, it's because we know very little. We're doing our best to figure out what's going on with very scarce data. And this is one of the other reasons that we really are advocating more testing. So I'll just wrap on that point. So I want to thank the 3 nerdy girls who made it this morning. And we actually had one more nerdy girl, Aparna Kumar, was listening in and helping us field a couple of the questions in the background. So thank you, all 4 of you, for joining us today. And thanks everybody for tuning in and your questions. I recorded, I know we didn't answer all the questions, but I did write them all down. And so we'll try to, I'll put those in our little back channel tracking system so that we can try and post those on as posts on Dear Pandemic. And I hope we do another live session, and I will be sure to post when that's going to happen. So thank you, everyone.
Thanks, Malia.
Thanks, Malia.
Everyone.
All right, bye, friends.
Bye.